You all to Pediatric Grand Rounds. I'm looking forward to a really stimulating presentation today, and I'd like to turn it over to our Vice Chair for Education, Dr. Sandrain Van Schaik, to get us started.
Hi, welcome everybody to Pediatric Grand Rounds. I am not going to be the one who introduces the speaker, but I wanted to take a very brief moment to remind everybody how we end up with such a diverse group of speakers and diverse topics. So we have a planning committee that's very engaged and really keeps an eye out or an ear out for good topics and good speakers, but we also welcome any ideas that anyone in our community has for an interesting topic or an interesting speaker. And that's actually how we ended up with today's speaker. One of our own faculty, Dr. Honora Burnett, contacted me and said that she knew Dr. Alicia Sarona Singh, that she had a very interesting story to tell, and could she come to Grand Rounds? And I said, sure. So if you have ideas like that, contact me. You can go through the wiki, and there's a little form there. You can just email me at my UCSF email address, and we will take your ideas into consideration. And with that, I'm going to hand it over to Dr. Honora Burnett, who will introduce our speaker.
Great. I'm pleased to welcome our Grand Rounds speaker, Dr. Alicia Sarona Singh, a highly accomplished psychiatrist, educator, and researcher who serves some of our most at-risk populations here in the Bay. As way of background, Dr. Sarona Singh graduated from the University of Colorado School of Medicine. She completed residency in general psychiatry at the Hospital of the University of Pennsylvania, where she was in the child and adolescent track, and was also chief resident for services located within the Hospital of the University of Pennsylvania, CHOP, and the VA. She then went on to pursue additional training in psychoanalysis at the San Francisco Center for Psychoanalysis and Fellowship in Child and Adolescent Psychiatry here at UCSF. Currently, Dr. Sarona Singh is an attending psychiatrist working with the Transitional Age Youth Program through the San Francisco Department of Public Health, as well as an attending psychiatrist within the San Mateo Medical Center. She is interested in applying psychoanalytic ideas in medical and community settings. I will share with you that Dr. Sarona Singh and I met over 20 years ago at our first jobs working in a secondhand clothing store, rags to riches. It doesn't surprise me that Dr. Sarona Singh went on to obtain many of her own riches, both personal and professional, including an accomplished medical career and a beautiful family. But her story and journey has not been without its challenges. Dr. Sarona Singh is here to bravely and powerfully share the story of her daughter, Esme, in order to increase our understanding of the physician-parent experience. In her own words, being the parent of a critically ill child who died changed the way I see my role as a physician, and hope that by sharing my story and experience, I can promote conversations about death and bereavement among physicians. Please give a warm welcome to Dr. Sarona Singh.
Thank you, Honora. I'm going to jump right in. Thank you very much for having me here today and for the opportunity to speak with you about my experience as a physician parent with a child who died. After medical school and residency, I promised myself I would avoid giving PowerPoint presentations whenever possible, so I don't have slides today. But I do want to be sure to tell you that I have no relevant relationships with commercial or industry organizations to disclose. My goal today is to speak about the challenges providers face in caring for a family enduring the kind of crisis we did, from the dual vantage points of being both a parent and a physician. It's my intent to focus on our shared humanity, the compelling and difficult feelings that arise in these kinds of situations, which are framed by the system in which we practice, and how these internal and external factors inform what we say and do. There's a limitless amount that I could say about this part of my life. I've tried to focus on aspects that are relevant to you as providers who work with children and their families, and so I've left some details out. I'm using excerpts from an online journal I kept contemporaneously during my daughter's illness to highlight some of the events and feelings as they unfolded. A copy of these was emailed in advance, so you can read along if you'd like. And I think they'll be put in the chat for those of you who didn't get a copy but would like to read along. There's time reserved for questions and discussions after I speak, and there's nothing that's off limits in terms of what is asked. Although I no longer cry most days or even most weeks, I have yet to make it through this presentation without tears and predict that today I'll be crying with you. Forgive me. I'm going to begin by telling you a little bit about myself and my family to provide some context for our story. As was said in the introduction, I'm a psychiatrist and live in San Francisco. At the time that Esme got sick, I ran the consultation liaison psychiatry service at San Mateo Medical Center. CL psychiatrists are the kind that hospital-based providers probably interface with the most. We treat medically and surgically ill people who have a psychiatric or behavioral problem, so we work on med-surg units. My husband Ash is an engineer and works in technology, and we have a son Enzo who is 5 now and was 2.5 when Esme got sick. Esme was born in January of 2017. It was an uncomplicated pregnancy and delivery, and she had no medical or developmental problems. She was temperamentally easy. After ignoring me and her for the first few months, Enzo was very fond of her, and we were settling into life with 2 kids, 2 young kids, and 2 full-time jobs. In September of 2017, when she was 7.5 months old, Esme began to show less interest in eating. She would nurse, but not for as long, and the daycare provider told us that she was eating considerably less than usual. She also stopped eating solids, which we just recently introduced. We noticed that her abdomen seemed swollen. She was fussier, less cheerful, and less easily consoled than usual. One Saturday, I took her to the urgent care pediatrician because she wasn't nursing very well and something just didn't feel right. She thought she had some kind of virus with a benign exam. The next day, I had to pump a lot of breast milk because she was barely nursing and she had no tears when she cried. So we took her to the ER at the advice of the nurse line. There, she saw both an ER doctor and a pediatrician. She got a bolus of fluids. Labs were drawn but not sent. Although they all noted her large stomach, her exam was otherwise reassuring, and she started to eat more after the IV fluids. The pediatrician offered to admit her and do an ultrasound of her abdomen, but didn't think it was absolutely required, and we agreed with her. We had been in the ER by that point for 4 or 5 hours, and she seemed better. We left and saw her regular pediatrician again the next day. Esme stayed home from daycare most of the next week and a half. I was in almost daily contact with her pediatrician. She thought the abdominal distension could be related to lactose intolerance, so we tried a lactose-free formula, but Esme wouldn't drink that, and her stomach continued to grow. During these 10 days, she stopped rolling over and barely smiled. She had a few episodes of inconsolable crying that lasted for up to 30 minutes, but it always seemed that right when I got to the point of calling or taking her in, she would calm and fall asleep. Esme's illness is divided in my mind into 2 parts. The first is comprised of the 6 days between discovery of the mass and her admission to the hospital, through the day that we got the pathology back and learned what kind of cancer she had. The second part is the time between getting her diagnosis and her death 2.5 weeks later. I'm going to read from the first entry, written on the 2nd day of her hospitalization, describing what happened a week and a half after the ER visit. So this is entry number 1. We went back to the pediatrician on Thursday, and it was only in the waiting room that I felt a mass in her tummy. The doctor found it too and ordered an X-ray. The X-ray showed some kind of solid mass stretching from under her ribs down into her pelvis. The next 24 hours entailed an emergency room trip, an ultrasound, 5 failed attempts to get an IV and blood work, and 1 successful one finally at 1:30 a.m. by the very skillful and warm pediatric anesthesiologist. An ambulance ride from San Francisco to Oakland, CT scans of her chest, abdomen, and pelvis, and surgery to place a central line and get a lung biopsy. Although we are waiting for pathology, the doctors think she has a hepatoblastoma that has spread to her lungs. We are adjusting to a new reality. Some moments feel like anything else in parenting, going through the day and attending to your baby, making sure Enzo gets fed and has a nap, trying to remember if you brushed your teeth. And then it just hits you. This is a total nightmare, but there is no waking up, there are no breaks, there is no miracle. During this first part of her hospitalization, while we were waiting for pathology, there were 2 incidents in which I thought Esme was going to die before we even knew what kind of cancer she had. I'm going to read a few excerpts about these incidents. So this is entry number 2. Today was terrifying. In the afternoon, I was nursing Esme and she seemed to gag. She was making this horrible, gasping, raspy sound that was kind of like a cry, but just a horrible guttural sound and a look of panic on her face, my baby's face. And then she started to turn blue in my arms. Her oxygen level went down to the high 20s and they called a rapid response. She was put on oxygen and her sats improved, but I'm not allowed to nurse her. She is in a weird, semi-asleep state, and I just can't even imagine how awful this is for her, how confusing and scary and disorienting. I feel like I can't do anything. I just keep hoping that we have the chance to repair this horribleness, to make up for all the ways I can't soothe and comfort her. She needs to survive so I can do those things, and we have to persist, aware of the worst possible things that could come in the next hour, tomorrow, or in the coming weeks or months without being consumed by them. And then entry number 3. Esme was transferred to the PICU overnight. They were concerned that her edema was compromising blood flow to her legs and feet for something called abdominal compartment syndrome, which thankfully she does not have. Although this was another horror on top of 5 days of agony, both Ash and I feel that she is safer here with more monitoring, and she does look more comfortable this morning. One of the hardest parts of Esme being hospitalized was my inability to do almost anything for her. The routines of mothering an infant are tactile and close and become quickly ingrained. Overnight, these routines were taken away, and the feeling of helplessness that arose was nearly unbearable. This is coupled with a near total dependence upon the doctors who happen to be rotating on service and the nurses assigned to your room each shift. The first night in the hospital, when we were admitted after midnight, I had to pee so badly after not going for hours while we were in the ER, but I didn't want to leave Esme alone in a strange new place, so I took her in the bathroom with me. For those of you without kids, peeing with a baby on your lap is a normal thing moms of babies do. But I remember how the nurse looked at me quizzically as if it was unnecessary. I asked that same nurse when and how I might be able to give Esme a bath. In my mother's mind, I was concerned about maintaining her usual routine, willing some normalcy on the trauma that was unfolding. He politely demurred. Right before she was taken to surgery, 12 hours after her admission, we were asked to sign consent forms for the lung biopsy and placement of her Broviac line. In the pre-op area, I asked the pediatric anesthesiologist and surgeon how many of these they had done. Their answers were comforting, but as soon as I asked the question, I realized it was largely irrelevant. We didn't really have a choice. And I doubt there was anything I was going to learn that would have made not proceeding with the surgery a logical decision. It was a moment of reckoning for me with how little control I really had. Another night, the attending came in along with some residents on evening rounds. Esme was barely asleep after getting almost no sleep for a couple of days. And I asked that he not turn on the lights while we were talking. He looked put off and made a comment that he didn't like to work in the dark and preferred to see who he was talking to. This seemed like an unnecessary thing to say to me, and it felt cruel. He wasn't doing a procedure, he was listening to her lungs, and there was enough ambient light in the room to examine her. No other physician had asked to turn on the overhead lights. Highlighting the fact that he was at work also felt unnecessary, as if I should care about his working conditions, as if those carried equal or greater weight than my interest in taking care of my baby. I wonder now if he shared my sense of helplessness, if he too was clinging to what he could and could not control about the situation. I'm going to read an excerpt that reflects how hard it was to have so much changed. So this is entry number 4. In the hospital, Ash and I split the night like we did when Enzo was a newborn. I'm not a night person, so I sleep the first part and Ash attends to Esme, and then we swap. Then I head back home around 4:30 a.m. to avoid Bay Bridge traffic and be there when Enzo wakes up. I miss taking care of her. I can't bathe her, I can't nurse her. Changing her diaper is a 2-person job, and holding her requires 3 people to set it all up. But have you ever put chapstick on a baby? I did that today. Her lips are dry, I think from the oxygen and the fact that she can't nurse. It felt sweet, and also I couldn't help but think how envious Enzo would be. He's really into chapstick. And yesterday I cut her toenails and fingernails, which was quite the challenge given how puffy she is from the extra fluid her body is trying to manage. Right now, taking care of her means being right there when she's being examined, asking for pain medication on her behalf, reminding them to increase her tube feeding rate, singing her back to sleep when she fusses, looking at her when she looks at me, making sure to turn her regularly and that no one puts her on her right side. Parenting stretches us in ways unimaginable, and I keep trying to remind myself that being good enough today may look so different, and in some ways so much more painfully limited, but that what I thought or what I knew or what other mothers know, but it matters no less to her. As a physician, I had a clear sense about the way that the hospital worked and what was being done, but most of what happens in a hospital is hidden from view of the patient. You feel as if you are a passive participant in this massive machine. It is at once entirely about you and has nothing to do with you. Every person who comes into your room is well-intentioned, but has his or her own agenda. Orders are written, but not communicated to the family. Or one person says something, but doesn't have an opportunity to tell the next person before she comes into the room. These types of things added to my sense of helplessness about the situation. And it's not hard to see how this could lead to angry feelings of parents toward providers. This becomes even more complicated if there are other dynamics that have strained the relationship between patient and physician. Some families are easier to care for than others, and we sometimes have unwelcome feelings toward patients that further impair communication and affect our behavior. This is especially true when we have difficulty acknowledging or articulating our own negative feelings about patients and families or their situations to ourselves, such as hostility, anger, and sadness. I'm reminded of a patient I cared for early in my tenure at San Mateo Medical Center. She was in her early 40s and had 3 young children. She had end-stage colon cancer, and although she had previously foregone medical care in favor of natural treatments or cures, she was now presenting and asking for treatment when it was obviously too late. She had not explicitly disclosed her condition to her children before this, but it was clear that her death was imminent. She had such advanced cancer that she was bedridden and had developed terrible pressure sores, which were infected and extremely malodorous, to the point that it was difficult to walk in the hallway past her room, much less be in the room with her. One day on rounds, while we were discussing her case, the hospitalist caring for her pulled up a picture of Pigpen from the Peanuts cartoon, and with a smirk showed it to the nurses sitting nearby. Although it would be easy to dismiss this as, at best, an attempt at gallows humor, or at worst, a lack of professionalism, I think it also reflected complex feelings of anger on the part of the hospitalist that this patient had made choices that led to her current situation, which was devastatingly sad and in many ways hopeless, and now we bore some responsibility for caring for her. It was impossible to not feel grief for her children as well. I think this behavior was a way to ward off those more difficult feelings. As a white parent, I did not have to bear the weight of racism in my interactions with Esme's doctors and nurses. Over the past 6 months, I have thought often about a patient I took care of shortly before Esme got sick. She was a young African-American woman with severe chronic health problems. I was asked to consult on her care due to some behavioral issues on the unit, which were limiting her discharge options. While waiting for a disposition, she contracted a nosocomial infection and was admitted to the ICU with multisystem organ failure. I was asked by the ICU attending to again become involved due to the concerns about the patient's mother's behavior towards staff. Her mother stayed by her bedside as much as she was allowed to, and this was pre-COVID, so she was there a lot, and frequently questioned nurses and doctors, which they experienced as hostile. The doctor had told her that the patient was not making urine and would need dialysis. The patient's mother angrily held up the Foley bag, which held 25 cc's of urine collected over the preceding 24 hours, evidence that, in fact, she was making some urine. At the time, I offered advice about how to best communicate about her daughter's care, but I did not consider or give weight to the ways that racism in medicine and distrust in the medical system may have justifiably contributed to this woman's anger. At the time, not a single doctor on staff at the hospital was Black. Now I'd like to share a bit from the second part of Esme's hospitalization, when we found out what kind of cancer she had, and talk a bit about how we made the decision we did. So this is entry number 5. Here are the facts. Esme has a very rare tumor called a malignant rhabdoid tumor, which has an incidence of 1 in 2 million. Even rarer is for it to present as it has in Esme, starting in the liver. In the best case scenario, treatment, chemotherapy and surgery, and possibly radiation has a 20% survival rate. In Esme's case, her odds of survival are less than 10% because she is under a year of age, her tumor is inoperable, and it has also spread to her lungs. A round or two of chemotherapy may halt the growth of the tumor or even shrink it, but almost inevitably, it would start to grow again, and she would need stronger chemotherapy or an experimental drug in a faraway city. And she would most definitely suffer during the administration of the chemo, being separated from what is familiar and loved to her, being poked and prodded and examined by a series of strangers, experiencing side effects and complications from the chemo, needing repeated hospitalizations and being put in restraints so she doesn't pull on her tubes and lines. These are the facts, but this is not a brain decision, this is a heart decision. And the best thing for Esme is to not put her through any more. I do think that giving treatment a try would make us, and maybe you, feel better, but it wouldn't be for her. When you take your children to get shots, you understand it will cause them pain, and you can look them in the eye and say, it's okay, and know you are being honest and your child trusts you. But we cannot continue to do things to Esme in the name of trying, and look her in the eye and honestly tell her that it's okay. She'll feel better soon, that this pain and fear are worth it for her. This is an anguishing decision for us to make. We want her remaining time to be peaceful, beautiful, loving, comfortable, dignified. We intend to stay in a room at the hospital designed for these things, that is to say, something more comfortable than the PICU. We would welcome a visit if you want to come, and we fully understand that this may be too painful for you to bear witness to. No one can really say about timeline, but we'll let you know. Our other task is continuing to parent Enzo. We do ask that you do not send suggestions about where we might get more information or a second opinion. We have verified what they have told us. We trust her doctors, and we have to face the reality of Esme's illness. There is no doubt about her diagnosis or her prognosis. What would be helpful is for you to shoulder this burden with us by accepting it. I had clarity about what the right thing was for Esme even before I knew the diagnosis. Right before the oncologist came in that morning to talk to us, I got angry at my husband for making a hopeful statement and said, nearly yelled something along the lines of, I am not going to torture her if she has a 5% chance of survival. I believe that my sureness about how sick she was and the decision that followed was primarily intuitive. My intuition was informed by being a physician. I could see how ill she was, and I knew what would be in store for her and for our family if we were to proceed with treatment. My intuition was also that of a mother who was inextricably linked to her daughter. I knew the oncologist couldn't tell us there was a 0% chance of survival, but I knew my daughter was not going to survive. This was a deep knowledge that I could not ignore. Coming to an agreement with Ash about how to proceed was difficult. I knew there was a risk it would ruin our marriage. I recall saying to the palliative care doctor, he won't be able to forgive me if we don't try, but I won't be able to forgive him if we put her through anymore. It took my husband 24 hours to join me in my conviction. Ash was raised in India, and because of cultural factors, but more importantly, because of his family structure, personal psychology, and early life experiences. Can you hear the psychiatrist in me? He is by disposition perpetually optimistic and hopeful. It's one of the traits I fell in love with. On the evening after he got the pathology results, he spent hours with the oncologist, asking questions, going over academic papers, doing online research. It still astonishes me that I did none of that at the time, but he did. It was part of the process he needed to go through. Accepting Esme's illness and death and our helplessness around it has changed the way my husband views the world. This has been another layer of loss for him. It was difficult too at times for her doctors and nurses to switch gears from treating to allowing her to die. In my lighter moments, I'm reminded of an Onion headline that reads, "World death rate holding steady at 100%. Death is a universal human experience and should not be a medical specialty, but that is often how it is treated. Certainly that's been my experience in medical training and practice. On the first night she was on essentially hospice, the resident team stopped by to discuss increasing the dose of her pain medication. One of them said something like, "We're not anywhere close to her ceiling." Based on the look on his face, I think he knew immediately that she no longer had a ceiling dose. I arranged to give this talk in January of this year, which, if you can remember, was a point in time before all of our lives were changed and spun off in a new direction because of the COVID-19 pandemic. Last week, the US surpassed 200,000 people who have died from the coronavirus. I'm not certain yet how much will change in terms of our collective cultural willingness to grieve and to allow others to grieve. Although healthcare providers in the Bay Area have been spared the overwhelming devastation faced by New York and some European countries in the spring, all of our lives are or will be directly or indirectly touched by death in some way during this pandemic. As pediatricians, you are likely seeing children whose parents' employment has been affected, who are struggling massively with remote learning and social isolation, who are grieving the death of a relative, or coping with being hospitalized for other reasons with significant restrictions on visitors. Being with other people, particularly during moments like that, death and dying, is an essential human need, and it is the exact thing that is necessarily limited right now at great cost to individual patients. At another point after we decided not to treat, I asked that all of Esme's medications be changed from PO to IV. I can't speak for other people's children, but mine absolutely hated getting medication squirted into their mouths. I didn't want my last moments with Esme to include me making her more uncomfortable or struggling with forcing her to take a medication. The physician initially said no due to the risk of central line infection. It wasn't until I asked if that would be a painful way for Esme to die that her orientation shifted. She didn't think that it would. There was also a nurse who asked more than once to check Esme's vital signs, although we had asked that that not be done. I didn't need to know that she was hypoxic or that her heart rate was abnormal. It's incredibly difficult to turn off this part of our clinician brains. Like stretching an overworked muscle, it requires a kind of letting go, setting aside our automatic assumptions about what is best, about what a patient wants. The second part of her hospitalization, when we knew that she was going to die but not when, was far more difficult for me than the first. I'm going to read an excerpt that describes some of what I experienced. And this is entry number 6. The past 10 days have been filled with waiting. Before we knew the diagnosis, we were impatiently waiting. We called the complaint line, we asked to speak with the ombudsman, we pleaded with anyone who would listen, even if we knew they couldn't do anything, to speed up the pathology report so we could know what we were facing and start down the road to something better. We felt like if things would just hurry up, we could avoid something bad happening before we even had a chance to help her. But knowing didn't bring something better, and instead things just got worse and worse. And now it's a different kind of waiting. The days are excruciatingly long. Every time there's a pause in her breathing, I feel like my heart is going to stop. ready for this being the moment that I lose my little baby girl. And then she takes another breath, and I feel relieved and also a stab of pain that I have to keep waiting and watching, knowing what is to come, but without any sense of when or how or who will be there. I don't know if I can bear to be there. Saying this out loud feels horrendous. I feel like I should be there, that I shouldn't be able to entertain any other possibility. Although with choosing to keep her in the hospital, Ash and I have accepted that most likely it will only be one of us with her. I remind myself that there is no one moment that proves what kind of mother I am. That the truth about what kind of mother I am arises from all the time we've had together. From the first moment, she was a little beating collection of cells inside me, until today when I held her hand and she squeezed back, and is not defined by this one moment. I hope that the kind of mother I am is evident by the choice I've made now, to let her be without pain and without fear, to parent her and mother her brother through a terrible loss. I hope it's true. Esme died on October 22nd, 2017, 3 weeks and 3 days after I discovered the mass in her abdomen. By the evening that she died, she was receiving a total of 72 milligrams per hour of IV Dilaudid. The way that things worked out, I was there with her, and my brother was there too. Ash was home putting Enzo to bed. Her death was not peaceful, and I believe she suffered, but this is a fact of life and death that I don't think could have been different as a result of anything our treatment team did or could have done. There were several instances in which Esme's needs were at odds with hospital policies. I'm going to describe 2 examples. The first is when Esme needed continuous pain medication. The oncology and palliative care physicians both felt that a parent-controlled PCA pump was the best course and proceeded to order and start morphine in a PCA. A few hours later, however, the oncology attending returned, saying both that they were told by the pharmacy that a parent-controlled PCA was not allowed, and citing some idea that I could feel responsible if she died shortly after administering a PRN dose. I pointed out to them that if any parent was equipped to understand how this option worked, it would be me, and that this was beside the point. Esme was going to die from her cancer, not from any medication I or anyone else might give her. Further, they themselves had agreed that this was the best option to control her pain and discomfort. The palliative care doctor argued effectively with whomever she needed to and advocated for our family, and we got what Esme needed. The second instance occurred after Esme died. Although we had asked specifically what would happen to her body, after she died, we were surprised and dismayed to find out that hospital policy requires the body to be washed and any lines to be removed. This induced panic in me. We had already confirmed that she could be cremated with her Broviac in place, and after she died, I had immediately put her in a sleep sack, and I didn't want her body to be touched or manipulated anymore. She had been through so much already. It was more than I could bear, and I told the nurses we wouldn't allow it. The nurse manager stopped by. He was very pleasant and professional, but it's never good news when the nurse manager comes to your room. Esme's oncologist was in touch right after she died, and I called her. She intervened, and we got what we needed. I think there is a tendency in tense clinical situations that we might not have encountered before, or that involve parts of the system or people we don't regularly interact with, to ask first what the policy says and not what is best for the patient. I am so grateful that Esme's doctor stuck to the latter, that they had the clinical wisdom and experience to do the right thing, and that they were empowered to do so. As my husband can attest to, I am by nature a highly rule-bound person, but these experiences have altered how I approach sticky situations, how I consider the best course of action. I hope any administrators attending today remember the weight and value of the relationship between a patient and her doctor. It felt sacred to us. Physicians need to be supported in bridging the gap between what is right and what is allowed in a way that is just and compassionate. Since she's died, I've spent a lot of time observing and considering what was and has been helpful and what has not. I could list a number of insensitive things people have said to us, but those lists are pretty easily found elsewhere. While I can only speak from my individual experience as a bereaved parent, my advice to you is also informed by my profession. And if there's one thing you take from what I have to say today, it is broadly this: say something. It is a basic tenet of psychotherapy that when difficult feelings can be articulated, they lose some of their destructive power. Acknowledge what is being or what has been lost. Although I think there's a greater societal problem when it comes to discussing death, especially the death of children, I do think that as physicians, we have a duty to rise above this cultural discomfort, to have contact with the pain of this kind of loss, to not leave people alone. There are myriad ways to do this, and I'm going to provide a few examples from our own experience. You need to use the words dying, died, dead. We use euphemisms to talk about something that is unspeakable. As I mentioned, on one of the first days after she was placed on hospice, during a discussion with the palliative care and oncology teams, we wanted to know what would happen after she died, like the actual concrete steps of what would happen to her body, where she would go. I was fumbling over this question, trying to get them to catch my meaning and what we needed to know. And in the end, I was the one who had to use the word dies. I found this extremely isolating. There's no need to pummel parents with the word, and you should follow a family's lead, but don't go through linguistic gymnastics to avoid saying it. This advice is commonly given to parents when discussing death with their children, but it's surprising to me how limited adults are in doing this with each other. At Enzo's 3-year well child visit, about 6 months after Esme died, we saw a new pediatrician. Their old doctor had left the practice shortly after Esme died. This pediatrician knew about Esme's death because I told her in advance, but during Enzo's appointment, she said nothing about her death. I found a new doctor that afternoon and sent a letter to her explaining why I changed. If she cannot bring up this loss, how will Enzo be able to confide in or trust her? It should have been one of the first things she mentioned or asked about. With some distance, now I believe that it was her own discomfort with talking about our loss that led to this upsetting clinical encounter, and she didn't mean to hurt us. But I wonder how it would have gone had she managed her feelings about death in a different way. Her inability to speak about what had happened placed a burden on us. Other ways to say something, to be present. If a family invites you to a funeral or memorial service, and you have the inclination and time to go, you should attend. Over Zoom, if needed. Of the dozens of providers who cared for Esme and said to tell them about her memorial service, and after we drove to the hospital to deliver invitations, only one nurse attended. If you can't go, send a note to the family. Her oncologist did that, and it was a comfort and an acknowledgement of the importance of our relationship with her doctor. The palliative care team sent a card to us on Esme's first birthday, and again on the first anniversary of her death. I can't tell you how much that meant to us. It was an acknowledgement of the enduring nature of loss, which has no expiration date. In our country, we are granted only a brief time following a death during which it is acceptable to grieve, but that is not how grief works. Consider sending a card to the family if you worked closely with them, or if you knew the child or sibling over a long period of time, on the child's birthday and the anniversary of the death. When I've had patients die, I've hesitated to reach out to the family or to participate in their grieving, even when I've been invited to do so, or I've been intensely involved in their care, worried that it would somehow be inappropriate, intrusive, or unwelcome. And obviously there are circumstances in which that's true. But I've come to believe that we worry excessively about making an error of doing too much and vastly underestimate the harm caused by pulling away. In the months after Esme died, I found myself especially thinking about a man with Down syndrome who I cared for. The patient had advanced Alzheimer's, and I spent hours with his sister, who had cared for him for years and really much of his life. I heard a few weeks later that the patient had died shortly after being discharged, and I thought about calling his sister, but I never did. I regret that deeply. Donald Winnicott was a famous British child psychoanalyst and pediatrician. He described the idea of a spontaneous gesture, which is an infant's unconscious, instinctual gesture toward the caretaker, generally thought of as the mother. In good circumstances, the mother responds to these and fosters a sense of safety in the infant, that his needs are being anticipated and met and enabling his true self to develop. The end-of-life situation is analogous in the sense of dependence upon another to meet needs that cannot be articulated. The providers who responded to our own spontaneous gestures, I believe, were the ones who did not disavow feelings of anger, concern, helplessness, and grief, but could access them and be present with us. I think of the PICU attending who only took care of Esme for one night, but who visited us on the floor when she was dying. The PICU nurse who also only cared for Esme for part of one shift, but a week later brought us a map of the stars on the night she was born, which now hangs framed in our home. If you are moved to tears by the loss before you, do not try to hide them. There was only one doctor who cried with me, an intern. At the time, filled with cynicism and anger, I had the uncharitable thought that it was just because she had only been a doctor for 4 months and it hadn't been trained out of her yet. In retrospect, I think there was something more about her that allowed her to have contact with the part of me that was in so much pain, in a way the other doctors didn't show me in quite the same way. It was an acknowledgement of the gravity of what was unfolding. It may not always express itself as tears, but I do think that you have to hold on to your sense of humanity and find a way to convey that to families and children. Being a physician entails, in equal measure, the acquisition of knowledge and a reckoning with the limited nature of knowledge. But what mattered the most, what became the only thing that provided some relief, had nothing to do with medicine. Because in these moments, these intense, life-altering, transcendent moments at which we as physicians have been granted the privilege and accepted the duty to be present, your medical knowledge becomes meaningless. But your capacity to have contact with a human facing arguably one of the worst kinds of loss one can know becomes paramount, a gift, something essential, not just for the family, but for you as well. Thank you.
Thank you so much for this fantastic presentation and a really moving story with lots of really good lessons in here. And I imagine that it's not easy for you to do this, but at the same time, probably an important part of your life now to help us learn these lessons. Honora, I'm not sure if you're still with us. I would ask the audience to share any questions that they have or comments through the Q&A function in the webinar. And Honora, if you're still on us, I don't know if you want to share some reflections or start off with questions.
This is Honora. Lisi, thank you so much for sort of opening yourself up to share your experience and story. I don't think I have any questions, and I'll open it up to everyone else, but I just appreciate from the perspective of a primary care provider too, just the specific things and items that you're able to give us to change our interactions with families and siblings who have lost someone. So thank you.
There is one question that just came in. Thank you so much for having the courage to share your story and help us be better physicians. What do you suggest we say or don't say when we call families to offer our condolences?
I don't think you have to say much. I mean, for me, the things that have been most helpful is just to acknowledge the loss. I mean, I think silence is the worst thing, to do. And I think sometimes it's okay to say, I don't know what to say, or I know there are no words that can sort of ease the pain that you're experiencing. But I think letting them know that you're thinking about them, especially if you knew the child, well, Sometimes, you know, I love hearing, my daughter was not even a year old when she died, so people don't have a lot of stories about her. But when I've met other bereaved parents, you know, they love hearing about their kid, you know, interactions that you might have had, a memory that you have and that you want to share. And, you know, it's likely to induce tears, but I think not being afraid of that and know that they're crying because they miss their child, they're not crying because you've hurt them in some way. I think those can be helpful things. And then, you know, being respectful about, you know, religion or cultural considerations, you know, and sort of making comments about that if it's appropriate, I think is helpful too.
I was wondering if I could ask you a bit more about, you know, you mentioned physicians going to funerals if they're invited, they should go, and how important that is. I'm wondering what your perspective is. So one of the things I personally struggle with is the grief that as a physician, especially I'm an ICU physician myself, that as an ICU physician you have when a child dies is very different than what a parent has. Not that I don't have that experience, but having experienced loss not of a child but of other people in my among my loved ones, it's just a different, it's something that you wake up with every day. And for better or for worse, the children who die in our ICUs, over time, our memories start to blur a little bit, and it's not as much with us. And so I'm always very conscious of the fact that my grief is much more of almost a temporary grief, an in the moment kind of grief, and that it feels almost sort of inappropriate to have that be too much at the forefront. And this is a very personal approach that I have, but I'd love to hear your take on that.
So is it that there's a worry that somehow you would be imposing your, you know, relatively smaller and, you know, smaller grief onto somebody who's sort of experiences profound loss?
Mm-hmm.
I didn't experience that. I didn't experience that people who took care of Esme, when they expressed their sadness, it didn't feel additive to my own. It didn't feel like it took away. You know, you're not going to the parent saying, I want to tell you about how sad I am. You know, I think there's something that would be inappropriate, but that's not what you're saying. I think what you're saying is, can I show it to them when they're already experiencing it? I don't think they'll experience that as additive, or that they're supposed to take care of you. Even for me, where it's very hard for me to step out of a physician role and not be a caretaker, I didn't feel that when people expressed their grief to me. It actually, the closer people were to her, like with my husband, for example, it was harder for me to tolerate being around his grief than other people. So again, I think this falls into sort of this cultural trap that we have, that talking about it or being with people around it is somehow going to make it worse, and it's better to sort of shy away from it. And I actually think in most cases that's probably not true.
Thank you. There's a number of other questions and comments. There's another comment of appreciation for sharing your story, and sorry for you and your family's loss. Another person says, thank you so much for allowing us the opportunity to share your insights from such a difficult experience. I was wondering if you have any suggestions in particular to help parents of patients who are also physicians. That is, how to let them decide when to bring that to the encounter or when they would prefer not to.
Sorry, could you repeat the question?
So I'll paraphrase it, because I think that the question is, when we are dealing with parents who are physicians, how should we invite them to take that into account, and say, well, I'd actually rather give them space to say, I'd rather not be the physician here. I just want to be the parent.
I have to say that I wish I had done a better job of asking Esme's doctors to treat me as a parent first. You know, they all knew I was a doctor. I I think giving people the option, I think that's part of the reason people didn't cry with me. They cried with my husband a lot, but they didn't cry with me so much. And part of me wishes that I had been more clear about that you need to talk to me as if I know nothing. And then, and partly because only half of us are doctors in my family. And so he needed to understand everything anyway. And so I think just having an explicit conversation at the beginning about how much detail people want, or how much, or just taking a stance that, I'm going to speak as if you're not a physician. I understand you are. I always say that I'm always a physician and I'm always a mother, and they inform each other. You can't just turn it off in your brain, but your brain's also not working so well in these circumstances. So I hope that helps answer the question.
Thank you. There are two questions that are more or less about the same thing, so I'm going to just ask one of them, and then hopefully they satisfy both questions. This was incredibly powerful. Thank you for sharing your story. I'm so sorry for your family's loss. Do you have suggestions for how we can better support siblings and parents who are grieving and caring for other children?
Yeah, that's a great question. There have been a few concepts that were really helpful to me, and they're medical analogies, so this is the right crowd for them, in terms of talking to Enzo. And actually, we've since had another baby. She's now 17 months old, so we think about this a lot. I think in terms of talking to our kids about Esme, one idea is to use pediatric doses of the truth. So what we tell him is always true, but what we tell him now is different from what we told him 2 years ago, and it's different from what we'll tell him in 10 years in terms of the level of detail and the way that we answer his questions. But we always tell him the truth. And that's been really helpful for us. And over time, he's asking questions when he needs to know something. And it's over a year before he asked what happened to her body. He didn't need to know that right away. But he knew he could ask us about it. Kids will fill in the details in their wildest imaginations if you don't give them the facts, but you also don't want to overwhelm them. The other concept that was really helpful for me in terms of grieving was, when we sort of realized Esme was going to die from her cancer, I felt almost as bad for Enzo to have this kind of loss so young. And somebody gave me this idea, but it's the idea that it's an inoculation against future loss, that Enzo will have, and our other baby, they will have losses in their lives, hopefully nothing as bad as this, but if they have internalized and have sort of a deep understanding that they will not be alone with it, that when something bad happens, they can talk about it, they'll be surrounded by people they love, then that will carry him through those difficult times. The last part I'll say is that, at least for pediatric cancer patients, I imagine all of you know about Campo Kaizu, but that has been a phenomenal resource for our family. It's an organization that helps families in Northern California with pediatric cancer. And although Esme never went there, we've been going, unfortunately it burned down in one of the recent wildfires, but they're still doing programming, and they'll continue to operate in some way, but it has been a phenomenal resource to connect with other people. Once you have a child who dies, the rest of the world has a hard time understanding it, but when you're around other people, and particularly for siblings, to be around other kids who have lost a sibling, it's incredibly helpful. You get to just be a kid.
Thank you. There's a couple more questions, so let's see if we can tackle a few more of these. Okay. You just told us that you're always a physician and a mother at the same time, but this question actually really asks about your thoughts as a psychiatrist. One of the attendees says, your story is tragic and your suggestions extremely useful. Having said that, you seem sure it's generalizable, and I'm not sure if all grieving parents would feel the same way about choice of words, etc. As with everything in life, we come to understand death in our own context, and I'm not sure everyone would want the same input that you did. Can you comment on that from your psychiatrist hat of view?
Yeah, definitely. And I hope I was clear that you should follow a family's lead, you don't need to pummel families with it. I've met parents who have lost children and, 10 years later, it's still hard for them to say the word died, and that's fine. I just think, and particularly for non-physician parents, it can feel really isolating that nobody can talk about it. And I think part of that and how we think about that is language. And you will know with a particular family if that's not welcome or important. But again, I think we are too nervous or too scared to say the words in a way that, at least for me and other families that I've met, can be very isolating. But absolutely, you're right. It's not going to be the correct thing for everybody.
Another question that came in from actually one of our pediatric intensive care trainees. Thank you so much for sharing your story with us. Such a powerful story and helpful in giving us a different perspective. You mentioned that when she died, it did not seem peaceful or comfortable. Is there anything that we as physicians, from your perspective, could do that could have improved that?
I don't think in our case there was. I mean, we were in the hospital, which is not very common, to stay in the hospital until somebody dies, but it was an option that was given to us and we took it. Yeah, I'm not sure there was anything different that could have been done. She couldn't have had more care, being in the hospital. Yeah, I wish I could have said something better. It's just a fact of life and death.
Yeah. Another question asked about insights on managing and processing the secondary grief that we experience as clinicians.
Yeah. I'm not sure how secondary it is. I mean, I think especially if you work closely with somebody, you can feel the loss of life. It's right, like you had been saying, it's not like the parent or a family member. There's some things that are helpful. They've shown that even, very brief debriefings following the death of a patient with a team in sort of a structured way, just to have a moment to talk about what happened and what feelings you have, can really help in terms of people's reactions to it. I don't know if that's something that happens at your hospital, but there have been studies that shown that people's sort of ability to understand death and sort of emotionally cope with it is improved. And I think, self-care, as a psychiatrist, I talk about self-care a lot, but finding ways to sort of nourish yourself and not just distract yourself from the feelings. I think self-care probably should not include screen time. So to not distracting, allowing yourself to feel it and move through it and then continue on.
And I'll take this opportunity to, for the audience, that we do actually have a Care for the Caregiver program at UCSF. And then our chaplain services run also debriefings after difficult situations, including bereavement situations for our staff. One more question, if we have time. I think we just have time. So grateful for your openness and eloquence. Could you comment a bit more on how you and the medical team navigated those 24 hours when you and your husband did not see eye to eye?
We had probably a 2-hour meeting with the palliative care team the morning after we got the prognosis. And they handled it just beautifully, but it felt like an iterative process, sort of just going back and forth between what I was seeing and what I thought and what my husband was seeing. And they were just so patient and sitting with us and until sort of we came to a decision. I think as much patience as you can show, and just there's so much reflecting that they did, and that was really helpful. Yeah.
Great, thank you. So I'm gonna end it here by thanking you again, and I actually will read the words of Will Hocker, one of our champions, who says, "Thank you, Lacey, for your love and your courage. You have blessed us all with this presentation." Thank you so much for being here with us today. I'm going to hand it over to Dr. Hirsch for a final comment, and just want to remind people quickly that next week we have a co-sponsored Grand Rounds, co-sponsored by the Children's Hospital DEI committee and the Residents Diversity Committee, with one of our residents actually speaking about affirmative action in California. So I hope you join us then. Dr. Hirsch.
Thank you, Sandra, and thank you, Dr. Sarona Singh. Everything I wanted to say has been said better by my colleagues, but I do want to just lend my thanks as well for sharing your story with us. It feels oftentimes that we, in medicine, we're trained to care for the body, the pathology, but I don't feel that we get adequate training on how to care for the spirit and the soul. And so we need to learn more about how to do that. And And your story today, I think, is one way to help us get better at that. So thank you. Thanks, everybody. Have a good rest of your week. Be well.
Thank you.